excited for this month. Dr. DeYoung and I are really thrilled to be here to talk a little bit about high-risk breast patients, whether they be breast cancer survivors or people with a strong family history. But let us start by introducing ourselves. So many of you know me. I'm Rebecca Dunsmoor-Su. I'm the Chief Medical Officer at Genève. I'm a menopause practitioner and OBGYN, and the evidence-based use of hormone therapy is a passion of mine. And so I really love to talk about where is it appropriate to use them, what are our other options. And let me introduce Dr. Claudia DeYoung. And Claudia, let you tell everybody who you are.
Hi, everybody. I am Claudia DeYoung. I'm a board-certified internist that did a women's health fellowship over 20 years ago. And bottom line is I worked in a breast clinic. I got a niche in breast health. So I am actually a breast health specialist as an internist who specializes in women's health. I run a breast clinic here at the South Sacramento Kaiser Permanente Medical Center in Sacramento, California. And then about 10 years ago, I was diagnosing, so many of my patients were being diagnosed with breast cancer that I started a breast cancer survivorship program within oncology. So I follow many of our breast cancer survivors along with the oncologist and sometimes solo, depending on if they transition to me solo. Obviously, cancer survivorship is a passion of mine, and really empowering men and women to deal with some of the sequelae that come along with the advancements in treatment. And then, in my breast clinic, I also follow all our high-risk patients, whether that be from a genetic mutation, family history, or I just counseled somebody today who had ADH, atypical ductal hyperplasia, on biopsy. So what our recommendations are with regard to screening and risk reduction options for them. So this is right up my alley, and I'm really excited to be here.
Thank you so much for that. So as we've talked about, this is meant to be a conversation. So I'm going to start just by asking you some questions, and please ask back. And folks in the audience, please feel free to put questions in the chat or the Q&A, and we will address them as they come up because we want to make sure everybody gets out of this session what they need. So Claudia, one of the things that we've talked about before is that breast cancer survivors can be premenopausal, perimenopausal, postmenopausal. They can be all over the place at the time of diagnosis, but often what we then do in terms of anti-hormone therapies cause a lot of menopausal symptoms and can really exacerbate those symptoms. So when you're seeing somebody like that, what do you do to start addressing those symptoms for them? What are some of the options that you really like to use?
Well, I think history taking is super, super important, right? Because that spectrum of symptoms can be various, from the hot flashes and the night sweats to the mood changes that occur. Then we get into, sexuality, whether it be body image, vaginal dryness. So I really think a history is important. And that's where, it takes time because,
Yeah.
A lot of patients, some patients are going to be forthright and say, oh my gosh, the hot flashes are awful, doc. Something's got to be done. It's really, interfering with my quality of life. But on some of the more subtle issues like sexuality and diving into that and the different components, I think not all patients are going to divulge. So if we don't ask, patients don't tell. So I think a good history is imperative. Are you specifically asking about the hot flashes and the night sweats?
Yeah, so one of the things that I find in my practice is, women know to come in for those, right? And I totally agree with you that talking about all the other symptoms of menopause and really addressing what their true needs are is critical. But often they show up because they have hot flashes and they know that they can get treatment for that. And, in your experience, most of our alternatives to hormone therapy really deal specifically with hot flashes.
Yeah.
What do you find the most helpful?
So I think there's pharmacologic treatment and
Mm-hmm.
non-pharmacologic treatment. If we want to be straightforward with regard to pharmacologic treatment, my typical go-to is the SNRI, serotonin
Norepinephrine. Yes.
norepinephrine uptake inhibitors, SNRIs.
Yes.
Effexor is my go-to. I do like Effexor, low dose Effexor. So for those of you who don't know about Effexor, it is, classically sort of an antidepressant, anti-anxiety medication. Low dose works really well to at least decrease the frequency and intensity of hot flashes and night sweats. I usually start at 37.5, usually go up, and many women need about 75 milligrams. I think the studies have shown that above 75, if 75 doesn't help, more is not going to help. Again, higher doses for depression, but for the hot flashes, I think 75 is usually my max. I like Effexor because you don't have to worry about any interaction with tamoxifen, where you have to with some of the SSRIs like Paxil and Prozac. But the SSRIs, Paxil actually is FDA approved, I believe, for hot flashes, and that can be used a very low dose, 10 milligrams QHS, or during the day, so at bedtime or during the day. So that is my go-to first line.
And I find that most women get good coverage for those. I know that the data tells us that you get about a 45 to 50% reduction in hot flashes with those, at least for the studies.
Yeah, and I think that's expectation. You're not going to totally eliminate them, but you want to make it's quality of life, right? Everything here in this discussion gets back to quality of life, which I completely respect in every individual. I think that's really important to make decisions that are best for you, that ideally you make with your provider, and that optimize your quality of life. So I think my go-to is the SSRIs, SNRIs. I do, depends on, again, the history. If it's sleep and night sweats, gabapentin can work really well at bedtime. Gabapentin, for those of you who don't know, historically is an anti-seizure med, but is used in various indications now, a lot with chronic pain, neuropathic pain, like diabetic pain. But we know that it can, for whatever reason, help night sweats and sleep a little bit. I usually start low dose at 100, and most women need about 300 from my anecdotal experience at bedtime. It can be used during the day up to 3 times a day, but it can, in some people, it can cause fatigue, tiredness, lethargy. Some people are not affected by it at all. So again, if the symptoms are at night, I sometimes go to gabapentin.
Have you had a chance to use Veoza at all?
I have. It's not my first line, because in part it hasn't really been studied in breast cancer survivors. I know it has not, but it's relatively safe. I mean, you do have to, unlike the others, have to do baseline LFTs, liver function tests, and do that, every 3 to 6 months initially, and then you can stop. There are some side effects I've had of some insomnia issues, but most people, and I only have had a few people on it, they like that. So again, it's not my first line, and I don't know, do you want to explain to the audience how, because I think it's fascinating, and this is
it's a great medication, and many of us who've been to Menopause Society meetings have been hearing about these candy neuron medications for the last 10 years that they've been in research. So just to qualify, the research center where I'm a medical director, we did a lot of the pivotal trials for Veoza, so I have a good understanding of how it works. And just so everybody knows, Veoza is first in a class. There's another one right behind it from Bayer that works in a similar way, but slightly differently, which has been studied in breast cancer in Europe, which is great. So we're going to have that one probably early 2025.
Great.
They're going to go in front of the FDA, hopefully late this year, early next year, because their studies are done. So Veoza is a candy neuron. So it's a neurokinin receptor inhibitor. And basically candy neurons are KNDY, kisspeptin, neurokinin, dimorphin neurons are in our brains. And they basically connect that pulsing GnRH center to the temperature sensing center in the back of the, all in the hypothalamus. And they're basically transmitting all those pulses to the temperature center, causing that normal range of temperature to go from here down to a very narrow range, which is why whenever you sort of excurse out of that narrow range, you have hot flashes. So what it does is it just blocks that transmission very specifically to that center of the brain. So you're not getting that narrowing of temperature center. In the pivotal studies, they saw about 70% improvement in hot flashes, with few side effects, insomnia being one, headache being another. In terms of using it in breast cancer patients, I know, there's when it first came out, there was a lot of concern because it just wasn't studied in them. They have looked at whether it interacts with tamoxifen and aromatase inhibitors. It does not interact with tamoxifen. Totally fine. They do process through the same liver enzyme as aromatase inhibitors, but the interaction is considered minor. And if anything, it slightly increases the dose of Veoza. It doesn't impact the actual aromatase inhibitor, which is actually kind of okay. So the FDA approved the 45 milligram dose of Veoza. They actually trialed it at 60 milligrams. It worked even better, but there was 1% more liver function changes, so they didn't approve that dose. So I tell my patients, even if you're getting slightly more than 45 milligrams, it just means it's going to work slightly better.
Yeah.
Then the other thing, a lot of patients are really scared of the liver function tests. That seems like a big thing. Like, why are we having to test this so often? What's going on? I do like for us as clinicians to understand where that comes from. In the Veoza trials, only 1% of patients really had any change in their liver function tests. And even if they did change, they usually went back to normal by a year and nobody had any liver damage. So I want people to understand it's not a huge liver risk. The reason the FDA is so stuck on it is previous medications in this class, previous to Veoza, that did not make it through trials because of safety issues, had significant liver impact. So the FDA is just being super cautious about this. We'll see if they put the same recommendation for LFTs on the Bayer drug when it comes out. I'm interested to see that.
Yeah, that's a great synopsis. I will do also want to give a shout out to the non-hormonal medications though, because I really do think that there are things, and they not all the data is out there to support them, with the exception of cognitive behavioral therapy. I think there's some really good data that cognitive behavioral therapy can help with hot flashes and menopausal symptoms. Now, what is cognitive behavioral therapy? It's something that is done by a psychologist, and I don't really, I mean, it's cognitive training in the brain and using your brain as a tool to, because the mind, body, spirit is connected. Now, most medical insurance programs, I think, will cover some sort of cognitive behavioral therapy, whether they'll, I mean, I work for Kaiser Permanente, and we tend to be a little bit conservative, and we actually have a 6-week program for our breast cancer survivors, just to treat hot flashes and night sweats, using cognitive behavioral therapy. I know that there's a free app called Caria, Caria.
That's great.
Yes, it's a free app for cognitive behavioral therapy. It's not specifically for menopause, but you could use it for sleep. You can use it for various other, symptoms where cognitive behavioral therapy might be therapeutic. So cognitive behavioral therapy, there is some data that acupuncture can be helpful.
Yeah, plus minus
it's kind
on
of
that.
plus
Some
plus
good,
or minus.
Yeah. But
and again,
no
I think
harm,
it gets
right?
back to the individual. Right, exactly. I mean, everything to life, one of my mantras of life is everything is a risk to benefit ratio, right?
Right.
So you have to try what works for you. We actually know exercise can be counterintuitive, but exercise and weight loss can be helpful. So, and just being smart and being mindful of triggers or patterns. A lot of people will say stress, certain foods, alcohol can absolutely be a trigger. Carrying a little fan around, dressing in layers. There are a bunch of different cooling blankets. In fact, I just got an email, cooling blankets, cooling pillows,
I'm
all different
a huge
devices.
proponent of the chili pad, which probably has a new name by now, but it's actually a mattress pad you put under your bottom sheet, and it runs cold water under you all night long. So as many on this call may or may not know, I am a breast cancer survivor, and so I've been through all of this, and the chili pad was what saved my sleep, quite honestly.
That's great. Great to hear. Now, chili, I thought it was, I do not have a chili pad. And I went online, and it's kind of expensive. So it
It
might be
is.
cost prohibitive for
It
some
is
people,
expensive.
but there
Yeah.
are some other, less expensive options on
Hmm.
Amazon and Googling things. So you've got to be creative and give yourself some grace and find what works for you. But there's a lot of options, you know what I
Yeah,
mean? Because again,
there are.
what we really want to stress is for most women,
Hmm.
the benefits of taking these anti-hormonal medications for at least 5 years,
Hmm.
absolutely significantly, it's the biggest bang for their buck to decrease their risk of a reoccurrence.
Right. And, I think that sort of leads us interestingly into, I on a regular basis get patients who come to me who've had breast cancer, and who have read something out there that says that by denying them hormones, we're actually causing them harm. And I spend a lot of time counseling breast cancer survivors that taking hormone therapy, especially in the first 10 years, but really any time, does increase their risk of recurrence. And I think that it can be a difficult discussion to have with them. And I want to sort of hash it out, because I think there are some books out there like Dr. Blooming's book Estrogen Matters that say, hey, maybe it's actually better to take hormones even after breast cancer because of all its health benefit. Um, I tell my patients almost everyone who's had breast cancer is being put on these anti-hormone therapies, whether it's tamoxifen or aromatase inhibitor. They're going to take them for 5 to 10 years, at which point hormone therapy has lost a lot of its health benefit for them. So even if we were to wait until they were done with that and start them on hormones, they're probably not going to get a lot of health benefit outside of bone health. But I think one of the confusing things, I have a lot of patients who show up and say, well, I've had a double mastectomy, so I can have hormones because I'm not going to get breast cancer again. But that's not true, is it?
That's absolutely not true. That's absolutely not true because, well, first of all, breast
Hmm.
cancer is a mischievous sort of cancer.
Yes.
First point is that even if you've had a bilateral mastectomy, even the best breast surgeon will not remove every breast cell on that chest wall.
True.
We also know that breast cancer cells can be quiescent for years and years and years and years and years and not active at all, and then something triggers their activity.
Hmm.
And again, there are no randomized control trials. In fact, as you probably know, the two that have been started back in the 80s were
Hmm.
stopped
Right.
because of the increased risk of breast cancer reoccurrence.
Hmm.
Now, I do though, let's get back to quality of life. I have
Hmm.
one patient, and I've been doing this almost 25 years. I have one patient, she's had a bilateral mastectomy for DCIS.
Hmm.
She clearly feels like the benefits of HRT. We don't call it HRT anymore. I think it's MRT, menopausal
MHT,
replace MHT. Yes,
menopausal hormone therapy.
hormonal
Yes.
therapy. She feels like the benefits to her, and she's in
Hmm.
her 60s, outweigh any potential risk. And we have gone through that.
Hmm.
And I am probably one of the few docs here where I work that would be
Hmm.
willing to prescribe that. But I see her annually for an exam. We check in. Is there any new data? How you doing?
Hmm.
Can we lower the dose? Never or not ever is sort of I don't like black and whites
Right.
because I think everybody's individual, but I really do get back to asking the question, why do you want exogenous hormones now?
Right.
Because let's get back to some of the pillars of good health
Hmm.
that can alleviate a lot of your concerns right then and there, or how can we do that
Right.
non-hormonally?
Right. No, it's a great point. And I talk to a lot of women. I have also in that a similar situation prescribed hormone for someone who's really, really struggling with their symptoms. And typically, if I'm willing to go down that pathway, it's someone who's had DCIS, who, is, many years out, still really having a reduction in their quality of life. And it may make sense for that person. But I think we're always balancing risk, right? And
Absolutely.
I know that a lot of people misinterpret the data on estrogen. So estrogen alone, when given to someone who has not had cancer, reduces the risk of breast cancer. But estrogen, even estrogen alone, when someone has had cancer, may increase their recurrence risk. So they're different populations. And we always have to
Absolutely.
think about when we're trying to interpret risk across different populations, who are we talking about? I will be upfront. There is one small study, and we're going to talk about it a little bit later with vaginal estrogen. So it's actually a large study. It's a database study, though. It's not a randomized controlled trial, where they looked at the use of, they were primarily trying to look at the use of vaginal estrogen after breast cancer to look at recurrence risk. And we'll talk about those findings when we get to the vaginal part.
Yep.
But they did have 800 patients in that study who had systemic estrogen after breast cancer. And in those 800 patients, they did not see an increased recurrence risk. In fact, a slightly decreased recurrence risk. But this is a very big database study. We don't have all the confounding factors. We don't know what their breast cancer diagnoses were. We don't know how long they took the estrogen. So really, you can't make a clinical decision based on that little bit of data. So I think, when someone is asking me for that because their quality of life is really impacted by their symptoms, that's one discussion. I think there are people out there encouraging women to get back on estrogen after breast cancer because it's good for your heart or it's good, and actually it's probably not at that point, especially if they're 5 or 10 years out. You're not giving them any health benefits. So there's no point in starting estrogen for that purpose. And I just like to clarify that.
For sure. I would agree with that.
Yeah. So since I brought it up, let's talk about the vagina because, I'm a gynecologist. I love to talk about this.
Love it. We don't talk about it enough.
No, we do not. Well, I do probably.
Yeah, you probably do.
But vaginal symptoms are huge in menopause for all women. So 50% of women all women who go through menopause will have some changes in their vaginal tissues. 50% are symptomatic from that. But I find the symptomatic population is much higher in breast cancer patients, especially those being treated, and especially with aromatase inhibitors.
Oh,
the
vagina just becomes so thin and friable.
Oh,
it's so delicate.
Yeah.
I mean, it just tears just by wiping sometimes. I mean, it's it's awful. And so, hopefully most women feel comfortable talking with their doctors, but you talk about affecting quality of life. It's a big deal, whether you're sexually active or not. Let's make that clear too. Or whether you have a male or female partner or, totally not, involved with anybody. Vaginal issues are a big deal.
They are a big deal. And I think, especially, tamoxifen does absolutely impact that. Aromatase inhibitors are worse. And I think the reason we're seeing that is that vaginal tissues are very sensitive to both estrogen and testosterone. And with an aromatase inhibitor, you're getting a complete blockade. You're not just losing your estrogen. So I think we even see harder to control symptoms. What is your comfort level with vaginal estrogen in breast cancer survivors?
So we actually, where I work, we have a committee on sexual health in breast cancer survivors, and we put together some recommendations. We definitely like to start with non-hormonal moisturizers and lubricants. I think there's a bunch that are good out there, and I would strongly recommend lubes, moisturizers, the hyaluronic acid suppositories, and Good Clean Love, just fabulous products out there. They're all sort of different. I like the
agree with you totally. Yeah. I tell women you need a skincare regimen in menopause for all of your skin. So you need a moisturizer. That's just baseline.
Yep. So moisturizers and lubricants, I think, go a long way. It depends on the symptoms. Sometimes we'll send them to physical therapy, and I think that's an underutilized service for many breast cancer survivors, because you can have pelvic floor dysfunction that can contribute to dyspareunia. And so seeing a physical therapist that specializes in pelvic floor dysfunction or pain can be very helpful. Sometimes a dilator, depending on the issue. And, most women don't know how to use dilators. So these physical therapists that are specialized can, in a comfortable setting, show women how to use dilators. So I definitely try to do non-hormonal local therapy first. Again, to your point, there have been several studies now coming out looking at reoccurrence using low dose local vaginal estrogen. And we try not to use the cream because we think we can get better control using either the tablet or the vaginal ring. And I think that there are breast cancer survivors who are better candidates for it than others.
Mm-hmm.
I think that I'd like to see them out maybe a few years if possible. I think that, a lower stage, lower grade node negative patient would be a more ideal candidate than, say, a stage 3 node positive young patient.
Mm-hmm.
We know that it's probably a little bit safer because there is studies have shown, especially in the beginning, a little systemic estrogen absorption if you're on tamoxifen, because how
Right.
tamoxifen works is that it blocks any estrogen at the receptors on any breast tissue.
Right.
So, tamoxifen would be the more ideal candidate than an aromatase inhibitor patient or somebody who's not on anything. But that's not it's not a hard stop. It's just more of the ideal patient.
Mm-hmm.
So that's I think in general. But I think it's definitely a discussion between the patient and the provider about the pros and cons and what we know
Yeah.
so far and what we don't know.
Right. And that's very in line with all the society recommendations. I mean, American College of Obstetrics and Gynecology says start with the moisturizers. If that's insufficient, then in tamoxifen, it's probably safe to use low dose vaginal estrogen because of the receptor blockade that aromatase inhibitors is a little bit more questionable. I I'll tell you, being a gynecologist and being the one who hears about these vaginal symptoms all the time, I tend to be a little more liberal with my vaginal estrogen use. My favorite's actually not the tablet or the ring. My favorite's Imvexi. And I love Imvexi because that oil base dissolves and gets the external tissues as well as the internal tissues. My issue with Vagifem tablets or the ring is that they treat the top of the vagina extremely well,
Yeah.
and they do not treat the vulva particularly well. And really, most of our pain receptors are on the vulva. So I tend to have a better luck and better control of vulvar symptoms with Imvexi, if we can get it covered for them, and it's still a controlled dose. I totally understand where you're coming from with the cream. It's variable how much they absorb when they use it. But I've had good luck. Like if somebody's using a Vagifem, having them use just a tiny amount of the cream just at the posterior fourchette
Yeah.
externally, they're not going to absorb systemically from there, and it can make a huge difference in terms of pain, especially back there.
I like that
Um,
idea.
so it's interesting where I am. A lot of the oncologists feel much more comfortable if I use Intrarosa or Prastrone, which is the vaginal DHEA product, which was marketed as, okay, it's taken up into the vaginal cells and converted into estrogen and testosterone there, and therefore seems to them like it would have less systemic absorption. Do you see that as well?
We here at where I practice have chosen not to prescribe that because we
Mm,
don't feel like there's good enough studies in breast cancer survivors yet.
interesting. Yeah.
So not that they can't get it outside of where I practice, but we do not offer it here.
Well,
Um,
it's interesting because like I've had several come back and who are especially the aromatase inhibitor patients, and they're getting the recommendation that this would be a safer option. I am happy to prescribe it, but I agree with you. I don't think the data is there that it is a safer option. And in fact, I think there was some data presented a couple years ago at the Menopause Society meeting that there is some systemic level of estrogen and testosterone when you're taking DHEA vaginally.
yeah, just through the mechanisms of how they all work together. And yeah,
Yeah.
so I, another thing I didn't mention too, sometimes, and I don't know if you've ever prescribed it, I occasionally, if there's a lot of pain upon entry, a
Mm-hmm.
little local lidocaine
Yeah.
on a cotton ball can sometimes
Mm-hmm.
be helpful. So there's a lot of
Yeah.
things. I mean, there's not one, remedy
There's
that
not.
fits all. You kind of have to
Mm-hmm.
experiment and give yourself some grace and love and just say, hey, I'm gonna try all these different things. And hopefully you have a provider that kind of
Right.
listens to you and cares and wants to work with you. Because I think
Mm-hmm.
it's a team approach for sure.
Yeah, I have used lidocaine. I do always warn people to let me know if it's causing irritation because some people can
Yeah,
become very sensitized to that because none of the lidocaine preparations are really made for vulvar tissue,
right.
which can be more sensitive. The other thing I always want to bring up because people do ask, there are several energy systems out on the market, whether that be Mona Lisa Touch Laser or the RFA devices. I I have used a Mona Lisa touch laser in the past in my practice, primarily in lichen sclerosis based on that data. Um, it doesn't have great data. for vulvovaginal atrophy. Unfortunately, the early data looked very promising, but once they finally did some sham controlled trials, which were very long in coming, they really showed no benefit over sham laser. Same with the RFA. The RFA basically has no data in these patients. So I can't, in good conscience, recommend any of those things for these patients, although some find relief with them. Always tell my patients, if you're going to explore those things, please see a gynecologist who is very experienced with these. Do not get your vagina lasered or RFA'd in a med spa
Yeah.
because they really don't know how to be safe with it.
Yeah.
And it should be, to be safe, you need to have someone who's taking good care, but really no recommendation for their use.
Agreed.
I know that
Agreed.
was the hope when they came out, was that this might be a great other option for our patients who shouldn't be on vaginal estrogen, but really it has not panned out, sadly. And then,
Go ahead.
oh, go ahead.
Well, I was just going to say, things evolve too. I mean, we're having this talk now. Who knows in 5, 10 years what options we'll have? I mean, this is for those cancer survivors on the call. I think, as scary of a diagnosis it is to get breast cancer, treatment is better, is good, better than it's ever been before. And survivorship has really become so much more well recognized and appreciated. And I think there's survivorship clinicians out there and other clinicians like Rebecca that have a passion for cancer survivors and quality of life. And hopefully you'll find somebody that just connects and listens to you. And again, keep in touch, because who knows in 5 to 10 years what options we might have.
Right. The other area we really wanted to talk about today, and is, an important area to address, is what do we do with our high risk patients? So not our patients who've had cancer themselves, but those patients who may have a strong family history or a genetic risk for breast cancer. And this is a really complicated area to discuss, right? Because everybody's a little bit different in terms of their risk. And, we use hormones in BRCA patients all the time, right? We put our young BRCA patients on OCPs to lower their risk of ovarian cancer while they're maintaining their ovaries. So we know there's safe ways to do this. And I will say that I'm a huge fan of hormones. I think they're great. And I tend to be very comfortable with them and having the conversation with patients about really assessing what is their baseline risk and what is the attributable risk to hormone.
Yeah.
And again, we're always balancing risk and benefit, right? If I have someone who has osteopenia at 48, who has horrendous symptoms, who has a mother and a grandmother with breast cancer, I'm going to counsel her that the actual attributable risk of taking menopausal hormone therapy for her is no different than for any other woman. One additional case of breast cancer in 1,000 woman years that she is adding on to her baseline risk. Her baseline risk is higher. So, we're not like, I think we used to think about it as like a multiplier. Like, oh, you have a 20% risk, and if you take hormones, it'll be 80%. That's not true.
That's certainly not true. I think there's so many nuances that it would be hard to really, you cannot cookie cutter it. You can't cookbook it. You really have to individualize. I mean, to your point, that 48-year-old, now it depends on her symptoms. If she has osteopenia at 48, and she's got a strong family history of breast cancer, I probably, unless I was giving her HRT for menopausal management, I would not treat the osteoporosis with hormone replacement therapy or menopausal replacement therapy. There's just better ways to treat bone health that way. And her fracture risk is overall low. We don't really treat the DEXA, we treat one's fracture risk. But say, for example, the example you had, your BRCA1 mutation carrier, who has a nipple-sparing bilateral prophylactic mastectomy and perhaps oophorectomy at the oophorectomy and, well, pincoectomy and hysterectomy, because there's a
Right.
rare risk of uterine cancer with the BRCA1s. But say she
Right.
has that at 35, which would be
Right.
NCCN earliest to do. We give her a little bit of estrogen back until menopause, because
Right.
we know it's almost standard of care to do so, and it would be
Exactly.
not standard of care not to. Why? Because we've studied these women,
Mm-hmm.
and by giving them just a little bit of estrogen back, we counter the increased risk of early heart disease, osteoporosis, cognitive dysfunction later in life.
Right.
So I think that's just, again, it depends on the situation. It depends on, the whole birth control pills. One questions, like, if you have a BRCA2 mutation carrier, statistically, many of the BRCA1 mutation carriers will get an estrogen negative breast cancer.
Mm-hmm.
Statistically, BRCA2 mutation carriers will get an estrogen positive breast cancer. And so
Mm-hmm.
you wonder, exogenous estrogens like OCPs, birth control pills, it can decrease their risk of ovarian cancer, but it depends on what their ovarian cancer risk is. Typically, it's much lower, 15, 20, up to 30%
Mm-hmm.
in the BRCA2. But if they have a strong family history of ovarian cancer in their family, then the birth control pills are probably worth it, because you
Right.
need 5 years of that, and you can really decrease your risk of ovarian cancer. And we don't have any screening tests. So it's just so nuanced. It's so
Right.
nuanced.
It is. It really is. And I think that's why really educating ourselves about all of these issues and taking each patient one by one, right?
Yep,
We need to understand,
absolutely.
what are their symptoms? What are they trying to solve for? I certainly don't recommend menopausal hormone therapy for someone who's just coming to me and saying, "Hey, I'm 50, I'm 52, I have a strong family history. I don't really have any symptoms, but I've heard it's good for me."
Right.
For her, it's probably not. The benefit does not outweigh the risk. But someone who's incredibly symptomatic and maybe
Yes.
has other factors like bone health and things to consider, the benefits may well outweigh the risks for her. And it's just a conversation. I take it as a great time to be talking to them about their screening plan.
Yes.
And really, and especially, I think with the BRCA patients, they tend to have a really solid screening plan or a plan for surgery. Like, they are well managed. I think it's these people with these sort of more nebulous family histories
Yep.
that maybe have extremely dense breasts and may not have heard that with a greater than 20% lifetime risk and extremely dense breasts, they actually may qualify for MRIs and being
Yep.
able to alternate MRI and mammogram. And getting a chance to say, "Hey, let's talk about the hormones and whether or not these are a good choice for you, but let's talk about how you're going to be screening yourself and how we make sure to keep you safe, whether or not you start."
Absolutely. Love it. And then, so when I counsel a patient, I talk about, genetics, family history
Hmm.
is one sort of topic. Then
Hmm.
you have screening based on the
Hmm.
family history and genetics and the personal history. And then you have risk reduction.
Right.
I counsel all my patients, whether you're a cancer survivor, just somebody who is at increased risk,
Hmm.
there are lifestyle choices that we can practice to reduce our risk of a reoccurrence, a new
Hmm.
cancer, or your risk of ever getting breast cancer. And I think that that's really refreshing for a lot of just many of my patients, whether they're
Hmm.
breast cancer survivors or not, to hear, because first of all, a cancer diagnosis is scary. And when you think
Right.
about, oh, I just get a screening mammogram once a year, like, how do we, like, what, there's nothing I can do. I can't, like, I just have to wait for my annual. No, you can be proactive, and there are lifestyle choices that absolutely can decrease your risk of a reoccurrence, a new cancer, or, if you have not had breast cancer, a primary.
No, that's absolutely true. And I know, talking about smoking and talking about alcohol intake and talking about eating red meat are great things to start with for patients. Um,
So can I just caveat with
yeah.
that? So I think smoking and breast cancer is a little bit more controversial. Alcohol intake, I think, even though there was a study that just came out that Kaiser Permanente did that showed that there was not an association, I think there's really good evidence that there is an
Yeah.
association between alcohol and breast cancer. So
Right.
I think abstinence is probably best in the breast cancer survivor, but I understand that alcohol is very social, and a lot of people just like a
Yeah.
little bit. So I always get, how much is a little bit, Dr. DeYoung? I tell my patients, to be honest, if
Hmm.
abstinence is probably best, but if you're going to drink maybe 1 or 2 glasses of wine, 1 or 2 times a week would be my max,
Right.
Now, I tell them, this is your bodies. You can drink
Right.
as much as you want. I'm just telling what I'm going to recommend. But we
Mm-hmm.
know, curbing the alcohol, we know a lifetime of physical activity, we know
Mm-hmm.
ideal body weight, especially
Yeah.
after they stop that endocrine therapy really makes a difference. And I think, I'm a big vitamin D lover. We can talk about
Mm.
vitamin D in a second. There is some data that a low vitamin D might increase your risk of a
Great.
reoccurrence. But when it comes to diet,
Mm-hmm.
this is my take on diet, and I'm really
Yeah.
passionate about
It's
this
tough.
because
Yeah.
it's tough because there's so many nuances. I think in general, the best diet, the best anti-cancer diet is a whole food, plant strong, less processed food diet. Now,
Yeah.
on that spectrum, there's a lot of different tribes. You can have
Mm-hmm.
the keto low carb, you can have the vegan vegetarian, you can
Mm-hmm.
have Mediterranean, paleo, everything in between. I think that everybody's body is different. Everybody
Right.
has a different microbiome. Everybody
Mm-hmm.
has food intolerances and preferences. So you can have any of those diets be really,
Mm-hmm.
really healthy with whole food, plant strong, less processed food, or you can be any of those diets can be terribly processed and awful.
Yeah.
But I think that, it gets back to a whole food, plant strong, less processed food diet. If you are going to do dairy and meat, I'm a big advocate personally, and I think some of the data supports this, that more regenerative farmed meat, chicken, eggs, and fish is better.
Yeah.
So ideally, we know that cattle that are grass finished, that live off the
Right.
land, we know
Mm-hmm.
that chicken and eggs that are pasture raised, not given GMO corn, their eggs and the chicken, they are healthier chicken, healthier beef for us. They're higher in omega-3 fatty acids, and they have less hormones, less antibiotics. Industrial farming, with all due respect, they really want to make their animals bigger, faster, fatter, faster. So
Yeah.
they are given a lot more exogenous things other than just nature to eat off of, and you consume what those animals consume. So I'm not opposed to meat, chicken, fish, eggs, but I think
Mm-hmm.
there's healthier versions.
I agree with you entirely. And, we talk about that just in general with our menopausal patients as a lifestyle change for long-term health, right? I mean, this is not just in cancer survivors. This is
Exactly.
the way all of us should try to eat, but it's hard. I
Very
think,
hard.
it can be very hard in your average grocery store to find truly grass-finished beef.
Yep.
It can be very hard to find those things. I think we're seeing more pasture finished chicken and eggs, the availability. But when I talk to patients about it, I'm like, you just have to be extremely thoughtful. So if you're going to continue to eat meat, get the best meat that you can that's raised in the most humane way, all those things, but maybe consider eating less of it.
I agree. And I'm also a big advocate of just being mindful of toxins in the environment. The
Yeah, oh
Environmental
God.
Working Group is a
Yeah.
wonderful organization. Dirty Dozen, Clean
Mm-hmm.
15. You don't always have to buy organic. Ideally, the Dirty
Mm-mm.
Dozen would be organic, but I always tell my patients, sometimes I can't find organic grapes, or I don't want to spend $5.99 on the organic strawberries, right?
Right.
So there's a lot of DIY washes. I
Mm-hmm.
personally have a cheap saltwater soak or a white vinegar and water soak where I'll soak my grapes or my
Mm-hmm.
apples or my strawberries in saltwater solution or white vinegar and water solution for like 10 minutes and then
Mm-hmm.
rinse. And that will remove nearly all the pesticides and herbicides way better than water.
Oh wow.
Dr. Greger from nutritionfacts.org has a
Mm-hmm.
wonderful little video on that if anybody's familiar with Dr. Greger and nutritionfacts.org. But the
Interesting.
Environmental
That's
Working
great.
Group is great because, again, they talk about how your skin is your biggest organ, makeup,
Yeah.
chemicals,
Mm-hmm.
water, just being mindful,
So
I
much.
think.
And how we're cooking, right? So we have to think about forever
Yes.
chemicals and our Teflon and, so many small changes, they do actually over time add up.
I think, and it gets back just to some of the pillars of
Mm-hmm.
health being exercise, good diet,
Mm-hmm.
sleep, stress reduction. I think sleep is underrated.
Oh
I
God,
think
sleep is
and
critical.
I also think that stress is something we sort of live in a constant of, and we're so
Mm-hmm.
immune to it, we just don't even realize the constant potential stress that our physical bodies are under that are
Mm-hmm.
and emotionally, and it's all connected, and
Right.
how that negative energy can sometimes, if not dealt with in a positive way, because
Mm-hmm.
we all have stress, can lead to disease
Mm-hmm.
over time.
Yeah.
Thank you, Britt. Thank you, Britt. You just put in the chat the nutrition that you found that. Thank you.
Yeah.
You're welcome.
No.
That's a good one.
Yeah. No, I totally agree with you. Sleep is completely underrated, and sleep is a huge issue for our high risk patients, but it's a huge issue for every menopausal woman. And earlier in our discussion, I did put in the chat, there's the CBTI Coach app, which is free to everybody. Cognitive behavioral therapy is one of the best mechanisms for dealing with sleep. It has been the most proven. It has the longest impact. It takes work. You have to really work on it, but it does make the best impact on sleep over the long term. Sleeping pills really aren't the answer to that, but we know that sleep impacts our overall longevity. It impacts our weight. We can't lose weight if we're not sleeping. It probably impacts our cancer risk. So we really need to deal with that first and foremost. And almost every menopausal woman has some sleep disturbance. So
Yes,
it's a
especially
thing
the
to deal
cancer
with.
survivor. I cannot
Mhm.
tell you the number of breast cancer patients who are like, I never had sleep problems until I
Right.
started these medications or whatever.
Right.
And to your point, I cannot echo cognitive behavioral therapy enough. It is something that
Right.
you have a toolbox that you will have for the rest of your life. It is very effective. It is not
Mhm.
easy. It's not a pill to fix it, but it works.
Yeah, and CBTI Coach is free to everybody, created by the VA for vets with PTSD. So
I've
it's
heard
out
great
there.
stuff about that. Yes.
It is not a bad app. It's not the most elegant app.
Not as user friendly
Well, I
as it
mean,
could
it's
be.
older and it was created by the VA. So you can
There you
imagine.
go.
But it works and it has all the pillars in there. And last thing I want to say about sleep is, do not discount sleep apnea. Women
Yes.
tend to have sleep apnea that looks different. They may not be big snorers. And sleep apnea really pops up in the menopausal transition as we lose muscle mass through the neck. So we just don't have as much support from our neck. So, low, um, I send a lot of menopausal women for sleep studies.
Yeah, I think that's a great point because, I think again, it gets back to history taking, an
Mhm.
important history of, snoring or depression or, are we missing? I mean, then we get into,
Mhm.
just thought of like, fatigue. Fatigue is such a big deal for cancer survivors. But I think as clinicians, it's important to, is it just, how is the sleep?
Right.
Make sure we're not missing any
Mhm.
supplements that could be causing it or medications or thyroid issues.
Right.
But the history is very important.
Very good. Well, I'm going to stop us there in our discussion. I want to make sure to give those who are in the session a chance to put any questions in the chat. So, or even come off mute or actually, I'm not sure they can do that. But please feel free to put something in the chat if you have a question for us. I was going to say there's one last thing I was going to address while we're waiting for any questions to pop up, which is the difficulty and I see this a lot. How do we determine a lot of women are started on tamoxifen when they're pre or perimenopausal as a treatment for their breast cancer or ADH or as a risk reducer? It makes it really hard sometimes to tell when they've become menopausal, right? Like they may have periodic bleeding, and when is that bleeding menses, and when is that bleeding postmenopausal bleeding, and how do you address that with women, because we know that risk of endometrial hyperplasia with tamoxifen is there.
Yeah, we know that the risk for hyperplasia is higher in a postmenopausal woman because they just don't shed the lining.
Right.
But it's much rarer in premenopausal women, more, just irregular menses. And so a lot of our OBs just end up
Mm-hmm.
doing an endometrial biopsy to err on the side of caution.
Mm-hmm.
And if it's benign, we kind of follow them. I think that although there's not a lot of good data about it, to know when a woman could potentially be postmenopausal, I typically stop tamoxifen for anywhere. I believe there's a European society that's similar to NCCN, but in Europe, they recommend stopping for 3 weeks. I think 2 to 3 weeks because it can affect FSH levels.
It does,
So
yeah.
I do stop tamoxifen for a few weeks and then check levels. What's
Mm-hmm.
more challenging for many of us in cancer care is the young woman who's been on Lupron and an aromatase inhibitor, and she wants to know if she still needs to come in for those monthly Lupron shots because she's been getting them. And the problem is when you stop Lupron, it can take several months for the hypothalamic you know, sort of a loop to normalize again. So you're never really sure if it's accurate or not. And those patients are really, really challenging.
Yeah, no,
So we
that's very
switched them
true.
to tamoxifen. So we stopped the Lupron and the AI, and then we put them on tamoxifen for a few months. And then, you know, we'll stop the tamoxifen for 2-3 weeks and then check and then kind of readdress it once a year.
Yeah.
And, but that could be tough. I mean, I
It
guess
can be.
those are
Yeah.
my answers.
Yeah, no, it's a tough thing. I always like to bring it up though, because I think not everybody realizes that tamoxifen does have an impact on the FSH and does drive it down.
Yep.
We expect them to look menopausal because they're having symptoms that look menopausal. But in fact, tamoxifen, always remember, is selective estrogen receptor modulator. So some places it does actually behave like estrogen.
Right. Right,
All
exactly.
right.
So they have a low estradiol level, but like an FSH that's still in the premenopausal range, and you're
Right.
like, what does this mean? And you know, the question
Means
is,
they're
you
on
know,
tamoxifen.
yeah, exactly, exactly.
Exactly. Well, I'm not seeing any questions pop up, so I'm going to say thank you. This was a wonderful discussion. I'm really glad we did this.
I
And
loved it.
thank you to everyone who attended today. And thank you also to all of you who are going to watch this later on, because I know August is a tough time for a webinar. But I think this is really helpful. I think, all the clinicians who watch this are really going to have that, a little bit more of the talking points, can understand the subtlety of treating these patients a little bit better and know where to reach for resources.
Love it. Thank you so much,
Take care. Goodbye, everybody.
everybody.